Welcome to part C of the cardiovascular and renal system. We are now talking about calcium channel blockers and the renin-angiotensin agents. So calcium channel blockers, there are three types of blockers. Dihydropyridines, benzothiazepines, and phenylalkylamines. Sometimes I can't pronounce words either, okay? These inhibits the passage of calcium into the vascular smooth muscle, and it has a dilating effect on the peripheral and coronary artery vessels. So, it inhibits passage into the vascular smooth muscle, so it changes how fast it can pump, and it dilates the blood vessels. It was approved for angina in the 1980s, quickly noted that the side effect of these was lowering blood pressure in high blood pressure patients. So this affects the contraction of the muscle. Well, contraction of the muscle is regulated by the amount of calcium ion inside the cells. When calcium enters the cell, muscle contraction is initiated. Calcium channel blockers block these channels, inhibit calcium from entering the cell, which limits muscular contractions. Different calcium channel blockers have different actions. Some are selective for arterioles, while some are selective for arterioles and the myocardium. The largest group is the dihydropyridines, which is one of those is amlodipine. Brand name is Norvasc. So again, we're looking at blood pressure. This affects peripheral resistance. Diuretics affect blood volume. This affects peripheral resistance. Because these inhibit the passage of calcium into the vascular smooth muscle, and it has a dilating effect on peripheral and coronary arteries. Initially, when these were first used, when benzothiazepines were first used, they were used in the 50s, but they had a lot of side effects. Now they're much more selective and they're better tolerated. Benzothiazepines affect peripheral resistance and cardiac output. Hold on. So in peripheral resistance, it has sympathetic nervous system activity. It affects the renin-angiotensin 2 system, and it affects the increase in blood viscosity. Stroke volume, it affects the preload, the contractility, and the afterload, and the heart rate. So it has many different activities. Calcium channel blockers, amlodipine, which is Norvasc, diltiazem, also known as brand name Cardizem, and verapamil is the generic for Calan. So amlodipine is generic for Norvasc, diltiazem is generic for Cardizem, verapamil is generic for Calan. And you'll be giving all of those medications over time. They're used for high blood pressure. They also treat angina, and some of these treat dysrhythmias, but only diltiazem and verapamil. Amlodipine has no dysrhythmia effects. They all inhibit passage of calcium into the smooth vascular muscle. They all have a dilating effect on the peripheral and coronary arteries. And the last two, the diltiazem and verapamil, decrease the SA and AV conduction, which reduces heart rate. If they decrease the SA and AV conduction, what do we call those drugs? Dromotropic. Remember, dromotropic, when we talked about the nervous system, dromotropic reduces the electrical passage through channels. So diltiazem and verapamil are dromotropes. Are you starting to see how all these different blood medications and all these different systems tie together? That's why this class is so important and so challenging. Calcium channel blockers do have side effects like every drug, but the side effects are usually minor and usually related to the vasodilating effects of the medication. So, flushing and headache, You know, if your blood vessels get wide, you could feel flushed. You could have a headache. Hypotension is a side effect, especially orthostatic hypotension, so getting up rapidly. Bradycardia, heart failure, and arrhythmias, but only in some calcium channel blockers. I'm so sorry, I'm just kind of choking today. It can cause edema, peripheral edema. Stevens-Johnson syndrome. These can be given without regard to meals, so timing doesn't matter in terms of timing with relation to meals. Ideally, you give these at the same time every day, though. You will always monitor vital signs before and after, obviously. You're going to look for paradoxical increase in chest pain related to severe hypotension. So these are used for angina, which is heart pain. But if a person has very, very hypotensive situation, that also will cause chest pain. Watch for heart failure, fluid accumulation, monitor liver and kidney function always. We're looking for altered tissue perfusion. So you look for capillary refill. Capillary refill should be fast. Drugs that affect the renin-angiotensin system will change the blood volume and the peripheral resistance. It decreases blood pressure and increases urine volume. So the renin-angiotensin system is a key mechanism that controls blood pressure and fluid balance. They've been used since the 80s. This is a key drug in hypertension, management of hypertension, because it affects both the pressure immediately and the blood volume. Sorry about that. Hot tea that was once cold. Hot tea is now cold. So the renin-angiotensin-aldosterone system is complex. Angiotensin is converted to angiotensin 2 and 1, and then angiotensin 2. When you have more angiotensin 2, you have increased sympathetic activity. Sodium reabsorption, potassium reabsorption, and water retention is increased. Arterial vasoconstriction is increased, and the blood pressure increases. Also, more ADH secretion, which is more water reabsorption. So we need to block that angiotensin 2 from being created, because that's where all sorts of bad stuff happens, right? Angiotensin 2 makes everything go up. So when you use an ACE inhibitor injects itself in between angiotensin 1 and angiotensin 2. It prevents the creation of angiotensin 2 and thus stopping all those after effects of the increased blood pressure and increased vasoconstriction and increased water reabsorption. ACE inhibitors, angiotensin converting enzyme inhibitors, or ACE inhibitors, are always prils. Captopril, enalapril. So remember, prils, angiotensin converting enzyme. Lisinopril is an ACE inhibitor. These are very commonly given. They're used in high blood pressure, heart failure, and myocardial infarction, or heart attacks, or specifically myocardial death. They lower peripheral resistance by causing vasodilation. They decrease blood volume by enhancing the excretion of sodium and water. So, going to urinate more, you're going to lose sodium, and you're going to vasodilate, which both of those drop blood pressure. It's cardioprotective. It prevents ventricular remodeling, which happens when heart disease causes heart death. And it decreases glomerular I can't talk today. Decreases glomerular filtration pressure. When you have higher pressure in that filtration system, more is pushed out. Well, it decreases the pressure, so less is pushed out. What are some considerations? One of the most common and annoying side effects is a persistent, dry, non-productive cough. A number of years ago, I had some blood pressure issues. My doctor put me on lisinopril, and I developed this persistent, persistent, dry, non-productive cough. It's just annoying as heck. That's called an ACE cough. And if you get that, you just have to change to a different medication because it is life-disturbing. You will need to monitor the BUN and creatinine. You need to monitor potassium, liver functions, and CBC. Administer 1 hour before meals or 2 hours after meals. Food will alter absorption. Avoid salt substitutes. Salt substitutes usually are high potassium, and that will change this effect. NSAIDs, so ibuprofen, reduce the antihypertensive effect of ACE inhibitors. African Americans have an increased incidence in angioedema, or hives. Angioedema is an acute hypersensitivity reaction that features swelling of the skin, mucous membranes, and other organs, and it may be life-threatening with laryngeal swelling, similar to an anaphylactic reaction. Monitor liver and kidney functions. ACE inhibitors are metabolized by the liver and excreted by the kidneys. Monitor for hyperkalemia, high potassium, which may occur due to the reduced aldosterone level. And monitor for dehydration or fluid overload because these promote water excretion. These are teratogenic, so category C, first semester, or category D, second and third trimester. So it depends on which medication you're using. Angiotensin converting enzyme inhibitors. They normally, approximately 10 to 20% of these people develop that cough. For a lot of people, it's not bothersome. For me, it was very bothersome. Usually starts within 1 week of starting the medication, but it sometimes occurs as late as 1 year into the medication. Stopping the medication, you may not lose the cough for about a month. Angiotensin II receptor blockers, or ARBs, have minimal risk of cough and therefore are useful for therapeutic alterations. So angiotensin II receptor blockers, these are always end in sartans, losartan, valsartan, sartans, S-A-R-T-A-N, like Cozar is a brand name. These block the action of angiotensin II at the receptor site. So your body still creates angiotensin II, but the angiotensin II can't work because these block the receptor sites. So it has all the same effects as ACE inhibitors with very few side effects. The side effects are usually related to hypotension or low blood pressure. FYI, ARBs are much more expensive than ACE inhibitors. So insurance companies are going to be less willing to pay for ARBs unless you can't take an ACE inhibitor. So we've talked about calcium channel blockers, which slow the heart and increase and vasodilate. We've talked about the angiotensin receptor system, which causes vasodilation and fluid excretion. So those two medications cover every aspect of high blood pressure. So consequently, those are frequently used together because they cover every aspect of high blood pressure. And when you use multiple medications, you need less medication of each to get the same results. We have a couple slides with questions that we will be discussing in class. Come back for Part D. In Part D, we're going to be talking about specifically adrenergic medications. And we just got done talking about adrenergic medications last week in class when we talked about the autonomic nervous system. Well, adrenergic comes back. See ya in Part D.